Welcome everyone to the Eyecare Experts, Dr. Bell, Dr. Terrezza, and we have with us Dr. Cow today. So thank you for joining us.
Thank you for having me.
Go through a little bit about your background and stuff, but today's topic, before we kind of dive into that, is talking about myopia. And myopia is just basically nearsightedness, and it's kind of confusing. Patients will say, well, what does that mean? Basically, it means it's harder for you to see things further away. But give us a little bit. Certainly, I think this is your first time joining us. So, where did you go to school? Where are you from? All those interesting things. Tell us about it.
Yeah. Thank you, Dr. Bell. So I joined Terrezza Optical back in December. I did my schooling in New England College of Optometry in Boston, Massachusetts. And I also worked a year out of school in Brooklyn, New York. I was at an OMD practice, or like an ophthalmology practice with a cornea and retina specialist. And on weekends, I also did fill-in opticals.
Okay. Well, we're fortunate to have you. Are you missing, do you wish you were up there doing some of the snow right now going on, or no? No?
Yeah.
It's record. I think it's record snowfall up there this year. My goodness.
Wait a minute. She's got to say where she went to college. One of the best schools in the
As far
country.
as optometry school, yeah, tell us that.
Yeah, so for undergrad, I did my 4 years at University of Florida. Go Gators.
Yes. Oh,
Very
yes.
good.
Yeah.
Everything brings you back here. It's funny. We're talking about all the different providers. I think we've got, I'm trying to think of all the different optometry schools, but I know we've got at least 5 of them covered, maybe
For
more
sure.
than that,
Yeah,
5 or
yeah.
6 of them. But we're lucky to have Dr. Cal. She's our newest provider, so thank you. Certainly, we're going to get into some of the things that interest you a little bit, and you can kind of dive into kind of what you're looking for, how you go about treating patients and stuff like that. But let's just start with myopia in general. Let's say a kid comes in, it's his first eye exam. He gets a pair of glasses or whatever to see. What do you tell the parents, kind of things to look for? Just kind of give us a little bit on that.
Yeah, so I always start off by explaining myopia or nearsightedness to the patient, the parents. I like to say as like the eyes are growing too fast, too long, too quickly. So we would like to kind of like control that before it's too late. So the earlier we start, the better the results are. So usually, we first go with glasses, and I like to tell people about a couple options for myopia management. So there is the Atropine drops, and there is also soft contact lenses or the MySight. There's the night lenses or the Ortho-K lenses, and now the newest Stellest lenses, which are glasses that are also made to help control the myopia.
And we're talking about increase. So someone who is nearsighted, let's say they come in and, I don't know, maybe they're -1, -2 or whatever. And this is a tough question, I guess, to answer is, how much are you looking at it progressing? I assume that, in general, most kids go more nearsighted, right, from an age until maybe 17, 18, or 19.
Right.
So if there's going to be already progression of somewhat, what would be an alarming amount where you say, hey, this is a little bit more than expected, maybe we should think about doing some of these things?
Yeah, for every patient, it's different. For like different populations is different also. So coming from like seeing a lot of Asian patients in New York, a lot of them are very nearsighted. Their parents are nearsighted, like high myopia, like -5, -6 or up. So they tend to progress a little faster than the patients I see down here, like Caucasian patients. And I would say if they're progressing like -1 diopter a year, that's pretty normal, especially if they hit like a growth spurt, we're expected to see some changes there. But anything like more than that, I would start talking to the parents about myopia management.
Well, I'm nearsighted. I mean, as far as like, I think we talk about genetics versus environment, what causes nearsightedness and what causes it to increase. I think if one parent is nearsighted, kid has a 25% chance of being nearsighted, and if both parents are nearsighted, a 50% chance. But as far as yourself, kind of what are you explaining? What are you looking for? What worries you, I guess?
Well, when I Of course, we haven't, this is a very exciting technological time. The Stellest lens, which is made by Essilor, which we fit, has a unique shape and a unique geographic plan to the lens. So there's a little spot in the center where you can still see the distance, but blur is introduced into the rest of the system, and you have a 71% chance you will not develop the nearsightedness that you were going to develop, even though that's an unknown. But they've done placebo studies and tested it against that, and therefore they came up with that data. This is FDA approved. So when I see a patient in the -2 range and they're in the second grade or third, I begin to talk to them about possibilities of doing the spectacle lenses to start with. And especially if they're non-technologically savvy and aren't interested in contacts or don't want to do drops for whatever reason, okay? But these are all FDA-approved techniques, and you need training in that, and you need experience like you do with any medical procedure, and Dr. Cow has that.
Well, I get the question a lot as far as why now? Why does it seem to be more of an issue? And it's not just a United States issue. I think this is a global issue where, more kids are maybe on the screen, looking at cell phones, looking at computers, looking at tablets, whatever that is for long periods up close. I know when we were young, we used to go outside and play the whole day and come in right before dinner. And I think nowadays a lot of kids are more locked inside for whatever the reason. And there are studies to show even just being outside with sunlight, that sometimes slows down the progression of it. But, being nearsighted, of course, like we said, it means it's harder to see further away. But as you said, it has to do with the eye being longer or larger, which increases the axial length of the eye. And so you can imagine if the eye, especially the back of the eye, the retina, the longer that axial length gets, it kind of stretches that retina and sometimes makes it thinner, which could make you more apt to have a detachment, a tear, or a hole. And so that's the reason we're concerned, because if a kid comes in, they're 5 or 7, and they're minus whatever they are, and they're going to change maybe for the next 10 or 12 years, maybe the starting prescription is a concern. But if it goes up a diopter or 2 diopters every year and then ends up being -20 or -10, that's where it can be a concern.
Right.
Yeah.
Yeah.
And we're trying to do all we can to slow down that progression, because in the long run, we don't want a high prescription. Nobody wants thick pair of glasses, but also it can do permanent damage to the eye, and that's what we're trying to avoid.
Absolutely. Studies have shown it's possibly linked to glaucoma also, one of the major causes of blindness in the world. And so treating it, anytime you treat a disease at an earlier stage, you're in much better shape than waiting until it explodes into a serious condition. And doing this with myopia could lead to prevention of serious diseases like glaucoma, like retinal problems, and the list is long without going through it all, but it's very encouraging that this could occur. Plus, when you wear a prescription pair of glasses and you have a lens, the quality of vision that you get is not the same as someone that doesn't wear glasses. We measure quantity, but we don't really get to quality. We do the best we can, but it's not the same. So if you can prevent the condition from getting to where a very thick lens is the only way you can see, then the quality of vision that you have with a much thinner lens is much better. And plus, cosmetically, people look better without big, thick glasses.
Yeah. And on someone who's nearsighted, usually the edge of the lens, the outer part, is where it's the thickest part. And that's where a lot of people can see, unless the frame hides it and things like that. But we talked about computer screen time, tablets, phones, all that stuff. What's the rule? We always say, parents will say, well, how long should he be on there? How often should he take a break? What's the rule we usually tell them as far as?
It's the 20-minute rule. They do 20 minutes worth of work. They take 20 seconds break time. And the third 20 is for what?
20 feet away.
Oh, there you go.
Yeah. So look at something
something.
20 feet away.
And
Yeah.
that's just to kind of release, or kind of that accommodation or focus, just to kind of relax it, because you're so locked in here, just to kind of give it a little bit of a break. So just simple things like that. I mean, we're just take a break, maybe go outside for a couple of hours a day. All these things are going to help you in the long run. You mentioned, we went through some of the treatment plans and stuff like that. I guess, and we can all kind of weigh on this as far as Atropine eye drops, as far as what that does, how often you use it, what would you tell a parent as far as outcome or what to expect using Atropine?
Yeah, so the Atropine drops are 1 drop in each eye at nighttime every night. What it does essentially is it makes the pupils a little larger. It makes things feel a little blurrier up close, and there's some light sensitivity. And the idea behind it is that you're kind of blurring the patient up close, so then they're not holding things as close to their face, thus like inducing less myopia in the long run.
Yeah.
Yeah.
And then Ortho-K, certainly, even when we graduated school, we dealt with Ortho-K. It was kind of on the scene, and it seems like, kind of went away a little bit, but now it's kind of coming back for various reasons, especially myopia and nearsightedness. But is there proven results with Ortho-K? We use Ortho-K certainly, so it kind of flattens, and I guess tell everybody what Ortho-K is.
Yeah. So Ortho-K has definitely been around. Ortho-K used for myopia management, though it's a little bit newer. So what it does is it basically feels like a retainer or braces, but for your eye. So you're sleeping with the lenses at nighttime, and it's reshaping the surface or the cornea of the eye, and it's flattening it. And the flattening effect is what corrects the vision for the nearsightedness. So during the daytime, when you take it off, your eye holds that shape, and it lasts throughout the day. And it causes some peripheral defocus. So the periphery is a little bit blurry, similar to the Stellest lens. Like, the technology is the same, and there is proven research. It does slow down myopia progression by about 50%.
Yeah, I think the retainer is a really good analogy. So, it's most likely a hard lens you're sleeping with. Is that right? Mm-hmm. Yeah. Stellest lenses, we went through that a little bit, but
Well, the Stellest lens was introduced in November, and its market share was 10 to 12 times what the industry expected it to do. So it's being adopted very quickly, and the results, clinical experiments showed that in 71% of the cases, it didn't get rid of the prescription, but it certainly slowed it down significantly, and that's very encouraging. And the other thing that it can be is, and you can combine techniques here too. So you can do the drops with Atropine, with Dr. Cow, or you can do the contacts in addition to wearing the glasses, and then try all three for different situations. You must wear the glasses at least 60 hours a week for it to hit its effective point.
So the bottom line is just come in. We need to, come in for that first comprehensive exam. We want to measure, see what the prescription is. Are you nearsighted? Are you farsighted? Certainly our goal is to get everybody seeing the very best that we can. And in this specific instance, we're talking about long term. And that's certainly with any patient that we see, we try to establish short term, long term, and we want to see you, from now on. And especially these kids, if it's changing dramatically, let's say there's being big jumps and spurts in prescriptions, we're just discussing ways that we can kind of maybe slow down or halt the progression so they don't, become very, very nearsighted and it becomes an issue. And some of these, as you said, have been around a little while. Maybe they're more tweaked now, but also we've got some newer stuff at our disposal as far as treatment options, so we can help these kids that maybe in the past, they couldn't be helped. So that's all good news.
Mm-hmm.
I agree.
Yeah. But the bottom line is come in, and certainly that's another reason we want to see you annually. At least, a lot of times I'll get a question of, well, hey, why do I need to be seen once a year or this or that? Well, most kids, their prescriptions are changing year to year. And we want to also get them to see the best, but also we want to keep track of how much it's changing. If we saw them 3 years ago, did it change every year? Did it how much did it change over a 2 or 3 year span? All these things help us to know the best way to treat and to manage, in this case, manage myopia.
Previously, those were all subjective measurements. Now we have instruments in our offices that measure the actual length of the eye down to a tenth and a hundredth of a millimeter. So small changes can be detected, and then you can alter your treatment plan based on the measurements and what they're doing. So if you're becoming very successful with it, you can continue along that line, and if you're not, then you can alter it by switching the mix of techniques. You might switch to atropine in the contacts if the glasses weren't doing what you expected them to do.
I was reading an article not too long ago where in some of the other countries, especially some of the Asian countries, where they're trying to mimic sunlight as far as certain lamps and lights indoors for kids that can't go outside, to kind of see if that will kind of mimic what the sunlight does to help also reduce myopia. Start reading, I think they're trying to do anything that they can. But any final thought, anything that we didn't cover, or anything you want to say on myopia in general?
Yeah, I just want to reiterate, like, the earlier we start doing something about nearsightedness, myopia in kids, you know, the less nearsighted the patient will end up in the future. So if they're at a -1 at age 6, you know, and then we start treating them, they might just be a -3 by the time they're 18, versus they could be like a -4, -5, or even higher if we don't intervene and do something about it earlier.
I know for me too, especially with families, sometimes that's a giveaway where you have a parent and they're very myopic, or their brother who's going to be 5 years older and his prescription this. So sometimes that kind of helps you to say, hey, little Johnny may be heading in that direction too. Let's kind of hopefully prevent him so he doesn't go down that same road that his older brother did, or something like that.
I think like any problem, when you spend money on the front end, you come out ahead. So if you look at the alternate ways to do this, to wait till these kids become adults, then you're talking about surgical correction with LASIK and other things, which has also side effects that sometimes may not be the best. But you're fixing the problem after it's already occurred. If you can fix it at the start before it occurs, that just makes a lot more sense.
So bring them in. Let's look at it. Do the full exam. Any eye turn issues, anything that we talked about treatment and what we're looking for, but also, these kids, 80% of probably what they're learning, depending on the study you look at, is visually. And so these kids that are in the impressionable age as far as learning in school, certainly we want to get them to see the best they can so they don't avoid tasks, because they may not tell you, hey, I can't see the board, or hey, I can't see as well out of my left eye as my right eye. They will just try to overcome that, and sometimes it's not obvious until we break it down.
The other thing is we tend to underplay it, but it's very important. The psychosocial aspects of wearing glasses. If you get picked on enough, you won't wear your glasses, and that makes you see even worse and serves as a stimulus to get even a bigger prescription. And in fact, you do poorer in school because you can't see worth a hoot. It has nothing to do with your intelligence or your ability to master a subject.
Well, this certainly is an issue, and it seems to be becoming more and more of an issue worldwide, and I know Dr. Cal specializes in most, if not all, of these treatment options, so we appreciate you joining us. Where are you at right now as far as locations? Where are you practicing at or seeing patients at?
So I'm at our downtown office at Palafox, and I'm also at Fairfield.
And so you can go to our website, terrezzaoptical.com. You can look at those locations, Palafox, Fairfield. We have a lot of information on our website. We have all the locations broken down with their own individual number. If you know which one's closest to you, you can certainly call that one. If you don't know, just give us a call, and we can tell based on where you live what might be the best one. Also, we have prior podcasts that are on our website if you like this topic, or maybe there's a topic you missed. We've done quite a few by now, so you can always kind of search it. We'd love for you to look at any of those things. And if you have any questions, or if there's any future podcasts, topics you'd like for us to talk about, certainly reach out to us. But we thank you for listening. Dr. Bill, Dr. Terrezza, and Dr. Cal, stay tuned for future episodes. Thank you.